Research at the University of Nebraska has been conducted to determine a pressure range which is high enough to insufflate the peritoneal cavity, but low enough to minimize preperitoneal insufflation during laparoscopic surgery. Laparoscopic surgery, or keyhole surgery, is a minimally invasive way of accessing the region between the intra-abdominal organs and abdominal wall. This region is called the peritoneal cavity. It is performed because of its advantages over open surgery and reduced risk of postoperative complications and physician-induced injury. Most of these complications occur during initial entry into the peritoneal cavity. Conventional devices to gain initial entry include the Veress needle, a needle with a safety mechanism used to blow up or insufflate the peritoneal cavity for viewing purposes in trocar insertion, and trocars, or ports that allow surgeons to pass instruments and cameras through to perform surgery. Trocars can be inserted with or without a Veress needle and vary in safety features. Insertion can be blind or performed under direct vision with a camera. Many procedures are often performed blindly. For blind insertion, there are tests to verify correct placement before the surgery continues. Among these include the pressure profile test, the double-click test, and Palmer's test. These tests are performed so laparoscopic devices are not inserted too far into the intra-abdominal organs or short into the abdominal wall. Research has shown that the pressure profile test is the most sensitive and reliable. Previous studies have found that the pressure to insufflate the peritoneal cavity is less than 10 millimeters of mercury, but the pressure of the abdominal wall had yet to be determined. The objective of this study was to find an optimal insufflation pressure range, which was high enough to lift the abdominal wall from the intra-abdominal organs, or the initial pressure to insufflate the peritoneal cavity, and low enough to prevent insufflation of the abdominal wall, or preperitoneal insufflation pressure. This range was determined to minimize preperitoneal insufflation while obtaining safe and efficient entry into the peritoneal cavity. The optimal pressure range was determined in pigs because of their similar tissue properties to humans. First, a Veress needle was inserted below the umbilicus using the double-click test. Starting at 0 millimeters of mercury, flow was increased based on the resolution of the pressure gauge until a drop in pressure indicated separation or peritoneal cavity insufflation. The Veress needle was then used to create pneumoperitoneum with the insufflator to reduce incorrect placement while testing preperitoneal insufflation pressure. A second insufflation needle was inserted in a random order at 4 anatomical locations: M for the midline, B for the lower quadrants, C for the upper quadrants, and P for the transumbilical region. Preperitoneal insufflation was marked by a drop in pressure before confirmation of entry by the double-click test. Here you can see a drop in pressure before a second click is heard, signifying the peritoneal cavity insufflation. After each incision, the pressure was increased. At the end of the study, it was found that higher insufflation pressure increased the probability of preperitoneal insufflation. There was also a significant difference between the mean initial peritoneal cavity insufflation pressure and each of the means of the lowest preperitoneal insufflation pressures. Pressures greater than 10 millimeters of mercury resulted in initial cavity insufflation, and pressures greater than 20 millimeters of mercury resulted in preperitoneal insufflation in porcine models. This defined our optimal pressure range. To avoid preperitoneal insufflation, the initial insufflation pressure should be within the optimal pressure range. This means incorrect placement will not cause preperitoneal insufflation, reducing laparoscopic complications. By knowing the minimum pressure required to separate the layers of the abdominal wall, the risk of preperitoneal insufflation can be mitigated while obtaining safe and efficient entry into the peritoneal cavity. Currently, this experiment is being performed on human cadavers to find the precise, optimal pressure range in humans and further reduce injury in laparoscopic surgery.